Good morning, good afternoon, good evening to all of our colleagues all over the world. Today, I have the pleasure of introducing one of the most famous oral surgeons in the world, Dr. Vishtasb Broumand. Dr. Vishtasb Broumand is an DMD, MD, graduated from University of Florida College of Dentistry in 1997, and subsequently from the University of Miami School of Medicine in 2000. He completed his postdoctoral residency training in oral maxillofacial surgery, along with an additional year of general surgery at the University of Miami, Jackson Memorial Hospital in 2003. He's completed a fellowship in head and neck tumor and reconstructive surgery at the University of Miami in 2005. He also served as an assistant professor of clinical surgery at University of Miami School of Medicine, Division of Oral Maxillofacial Surgery in Florida, 2005 to 2006. And he's also in a private practice in 2006 to 2012. So I can go on and on and on, Dr. Broumand. It's my absolute pleasure. I would like to also go on and talk about what Dr. Broumand's doing. Now, currently, Dr. Broumand's living in Arizona, and he has his new institute, Total Dental Implant Solutions, which he teaches zygomatic and tragoid implant placement. And he has courses and also mentorship courses that doctors can do live surgery. And Dr. Broumand, it's my pleasure to be here introducing you.
Good morning, and thank you so much, Dr. Javi. Thank you for the very nice introduction. It's a real pleasure to be here. I appreciate you guys having me here. It's real great to be part of the Global Summit and the Academy of Oral Surgery.
It's a pleasure to have you.
Yeah, thank you again. Thanks for the very gracious invitation. So I as you mentioned, I started out in Miami, and somehow I ended up here in Arizona about 7 years ago. My practice, the bulk of my practice, has now become full arch reconstruction and zygomatic implants. Of course, most of the cases that I see are extremely atrophic mandible and maxillas. The topic of today's discussion is obviously the maxilla, so a lot of them are zygomatic implants and pterygoid implants. And just this week I did 2 cases. One was a full mouth upper and lower, and one was just zygomatic. So, and of course, they were both zygomatic cases, and they were both mentorship cases where doctors from out of town came and they performed a surgery with me. So it was kind of nice, where we did things the way we did it in Miami. It was see one, do one, teach one. That's how we did it in Miami, and that's how we're implementing it here at Total Dental Implant Solutions in Desert Ridge Oral Surgery Institute. And we'll talk about that. But that's what I love doing. There's a lot of hope for these patients. A lot of our patients that are completely edentulous, that have been wearing a denture for a long time, and they've been told you have no choice but to wear a denture. They have hope. There's options for them.
Absolutely. Absolutely. That's amazing, Doc. That's amazing.
Yeah, when I first started doing zygomatic implants back in 2003, and I have to thank my good friend and mentor, Dr. Edmund Bedrosian, who I admire deeply. He's in Northern California. He was at Highland Hospital. He still is. And, I learned zygomatic implants from him, and spent a little bit of time with Dr. Brennemark, who was the founder of this technique. At that time, there was only maybe 150 oral surgeons in the country doing this technique. And now you have lots of oral surgeons, you have lots of periodontists, and you have lots of general dentists that are doing this technique and doing it well. So the key is to get the training, doing it the right way, and learning how to do this properly, and mastering it. So it's the more training you get, the better you get at it. And it's not just it's not one of those things where, I shouldn't just say, see one, do one, teach one. It's see many different, courses, do
Right.
it on skulls, do it on cadavers, do it on, on patients. There's multiple courses. Obviously, I've taught courses in Brazil. Going to Brazil is really difficult because you have to fly all the way from, for you and me, from the West Coast to Florida, and then from Florida to Brazil. You close your office down for a week. It's definitely not profitable and definitely not enjoyable and cost effective to do
Right.
that. So now that we can do this here, right here in Arizona, it's definitely the smartest thing to do
That's amazing.
in the
That's
state.
amazing.
But I tell people to take as many courses as they can and then start doing this. But in the last year, I trained 72 doctors through my institute. So it was nice. We had
That's awesome.
72 doctors come through 5 different courses, and they're all doing zygomatic and pterygoid implants. I also trained some doctors on mandibular, all on 4s. They weren't ready to take the leap of faith to do zygomatic and pterygoid implants, which is fine. I mean, we start where we're comfortable. We don't want to be pushed.
That's right.
So that's what I've done.
Fantastic.
Yeah, so it's great. And I think after I go through my presentation today, everyone will kind of gauge to see what their level of interest is and whether they even want to do this. Some people might say, "Oh, it's too complex for me," or some people say, "Well, this is exactly what I want to do."
That's right. That's right. Well, we can't wait to see, Doc.
Yeah, thank you,
Thank
you.
you.
I look forward to showing what we can do.
Perfect.
Yeah, so let me go ahead and get started on my presentation, and
Thank you.
then we'll go from there. So I'm gonna
Perfect.
start here with the presentation, and let me start sharing my screen. There we go. Great. All right, so can everyone see my screen then?
Yes.
Great. So reconstruction of the severely atrophic maxilla with zygomatic and pterygoid dental implants is my passion. This is what I do. At any point, if anyone has any questions, they can shoot questions over to our Instagram page or handle. It's Broumand oral surgery. Broumand hashtag oral surgery. But this is a typical case that I've done where a patient was wearing a denture for a long time in the maxilla, and they were told that they had no option. So this is the case after we did 2 zygomatic implants on each side, and they're quite pleased with the outcome. They got a bilateral quadruple zygomatic implants. But that wasn't always an option for these patients. Let me see if I can. I'm able to advance my slides here. Oh, there we go. So this is one of my typical courses. These are the Norris medical implants that I use. So when doctors come to my courses, we practice on these skulls, these plastic skulls for a day. And we lecture for an entire day before we start working on actual patients. So it's lecture for an entire day and practicing on skulls before doing it on patients. But this is the way I used to do these. So back when I was in my training, before I did I did a fellowship in head and neck reconstruction after I finished my oral surgery residency. And when I would see a lot of patients that had very atrophic maxillas, and the only thing we could do for them was take a big piece of anterior or posterior hip, like 8 by 10 centimeter block. We would remove that and cut it into 2 or 3 pieces and screw it into the maxilla, as you can see here, and hope that it wouldn't resorb, hope that it wouldn't reject, and obviously we'd have to undermine the tissue a lot, close it primarily, and hope that we wouldn't get dehiscence. We would tell the patient they couldn't wear a denture for months. Obviously, there was no chance for immediate loading, and these patients would be miserable for a while. Obviously, they couldn't go to work for a few weeks, and at the end, you would have a pretty good outcome if everything turned out well. You would go back, remove these screws, place implants, do a vestibuloplasty and a skin graft, and do a fixed restoration. The whole process took about a year. And what's interesting is some people still do this. They still do this. It takes about a year. But it's not enjoyable. There's no immediate gratification for the patient or for I rarely do posterior or anterior hip block grafts unless someone's had massive amounts of radiation or infection and they're not a candidate for implants for some reason. But this is a thing of the past, and this is how we did it before evolution of angled implants and graftless solutions. Everything we do now is aimed towards our graftless solutions. And this is another option that I did. We would take a piece of hip bone and shape it like a horseshoe, like the maxilla, and place the implants through there to the remnants of the edentulous maxilla, and try to put the right amount of torque so you wouldn't compress that maxillary, that sandwich portion of maxilla too much, and try to go back and uncover this 6 months later. Sometimes that worked and sometimes it didn't. But now we moved on. So a lot of times in my practice, on the upper right, we see a zygoma hybrid case where we have a couple of zygomatic implants and a couple of conventional. One on the bottom, you see the quad zygoma. So these are more for moderate or extreme atrophy cases. And now we can load these immediately. These are more predictable and give the patient a better, more permanent solution. So how did these come about? Well, actually, pterygoid implants came about first in the 60s and 70s, followed by the zygomatic implants in the late 80s by Dr. Brannemark, and the tilted implants by Dr. Mallow in the late 80s. Now the all-on-4 concept, but in general now the all-on-4 concept is taken over. It's more common, it's more prevalent because it's easier, and obviously zygomatic implants and pterygoids are a little bit more invasive, and not as many people are doing them. So like I said, if you have any questions, feel free to shoot me an email or send an Instagram message, anyone at this point. But talking about zygomatic implants, what makes them so possible to do? Well, we have lots of bone that's available to us. And remember, I'm not talking about conventional all-on-4 implants here today. That's not the topic of this discussion today. But if we look at the zygomatic bone, it's that orange bone right there in the middle. The anterior posterior length of this bone is anywhere from 14 to 25 millimeters, which is why the threaded portion of zygomatic implants is usually about 12 to 16 millimeters, depending on what company is making these implants. So the zygomatic bone ranges in thickness from 7.5 to 9.5 millimeters, which is why the implant diameter is usually about 4.2 millimeters. So after you place an implant, slice about a third of that zygomatic implant is in direct contact with bone. So like I said, the range is 14 to 16.5 millimeters. So you get primary stability by 14 to 16 millimeters of that implant, which is significant. Now it's important to keep in mind, we're placing that implant coming from the underside. So you're entering the zygoma from the oral cavity, obviously. So you have to keep in mind that there are vital structures around, and we'll go over all that. So the most important thing to keep in mind when you're placing zygomatic or pterygoid implants is the possible complications or possible danger zones that are available or that are in the region. So you have to just keep in mind what can go wrong. And obviously, today we're just talking for about an hour, but that's why when doctors come to me for a course or a mentorship, we spend a whole day on this and we go over everything in detail. But how is this possible? Why is this zygomatic bone so great? And let's say a patient comes to us and they've had 2 or 3 all-on-4s. Well, if you think about it, the mandible is hinged, right? But the maxilla is not. So there are a few sites in the maxilla, such as the nasomaxillary buttress, the pterygoid plates, and the zygomatic maxillary buttress, that have masticatory muscle attachment, just like the mandible, right? Unlike the hinged mandible. that have very dense D1 and D2 cortical bone concentration. So remember, the mandible is dense bone. So usually the maxillary alveolus is not dense. That's why you have all on fours that fail in the maxilla. So therefore, we're able to take advantage of this very dense bone in the zygoma and in the pterygoid regions and sometimes in the nasal region to place these implants and get very high primary stability, which leads to the concept of successful graftless solutions for these implants. And we've been doing this now for years with great success. Dr. Brandemart first did it in 1987 to 89. His implant at first was a straight implant with a slot in the bottom. It had threads going all the way to the top. It was an external hex, which later on he came up with a 45-degree head. After about 10 years, they still have that. Nobel Biocare still sells his implants, and they have a whole wide variety of them. I don't use that system anymore. I was trained on it, but they had anywhere from 30 to 52 millimeter implants. But there's a whole host of implant companies that offer this. As I mentioned, I use the Norris Medical Implant System now because it promotes the extramaxillary system. In my hands, it works better. It's easier, less complications, and it's easier to use, and it's a better aesthetic and prosthetic outcome. And I'll show you why. As I mentioned, zygomatic implants are a graftless solution for severe resorption or moderate resorption in maxillary bone with an immediate load protocol, which is what's great about this implant. Whether you're doing kind of grafter your maxillas or doing sinus lifts or anything you've done in the past, you can't do immediate load on anything except zygomatic implants. So obviously, same thing with all on fours. Patients that are candidates for all on fours, you're doing immediate load, but oftentimes a lot of patients are not a candidate for all. And this is how we did it before. We placed these zygomatic implants. This is a conventional zygomatic implant in the past with the intramaxillary technique that I used, Nobel Biocare implants. The major drawback to these implants, which is why I don't do them, is because you had to make a major a window or slot in the sinus, and you had this long implant carrier that was removed, and once you removed it, you could not change the position of the implant, as the mount was very difficult to replace. So that's what made things very difficult for these kind of implant systems. So now with the mountless implants, and I think Nobel's now done that too, where they made a mountless implant. But with the mount-free implants, life is so much easier. But this is an older system where you had a mount on these implants. But if you look at the older implants, they had a round apex throughout the entire, at the end, and you had threads throughout the entire length of the implant, which made things a little difficult to work with. One of the other major drawbacks was once the initial drilling started, because you were starting at the palate, going through the sinus into the underside of the zygoma, you couldn't change the position of the implant, as you can see here. So therefore, initial accuracy was very important in determining the site of the final implant. So they've changed things and tapered their apex instead of being round, which is important for immediate load, and the body of the implant is not smooth without threads. So, obviously a lot of there's a lot of new players to the implant, zygomatic implant arena. There's Neodent, there's Straumann, there's Southern, there's Swiss implants. I can't even name them all. But like I said, in my hands, I use the Norris Medical Implant System. And it works fabulously. It works great. And I'll show you some great cases. I'll show you cases that I've done with almost all the systems, but in my hands, that's what works great. This is just showing a cross section of what you're doing. You're going through the palatal bone from the underside trying not to perforate the sinus mucosa all the way through that alveolar bone to the antral wall and to the underside of the zygoma, getting bicortical stability, not really perforating too far out the zygomatic bone, yet getting multicortical anchorage, which gives you high, primary stability by getting at least, you're trying to get at least, the goal is to get 12 to 14 millimeters of primary stability. That's your main goal. So Brandmark looked at these implants and they found that they had at least 95% success rates after about 10 years. So most that are implants did very well. They only had a few that failed throughout those few years. And they attribute the success and failures to the biomechanics of these implants. It's a great product, and the same holds now. The success rate for these implants is about 95 to 96%. So indications for these implants is severe atrophy, moderate atrophy, or no atrophy at all. In my hands, obviously most of my patients have either moderate or no atrophy, or obviously, I'm sorry, severe atrophy. So there's two different techniques for this. There is the intramaxillary and there is the extramaxillary technique. So keep in mind, when the old technique was first presented with the intramaxillary technique, with all the newer implants, as I mentioned, they have now developed extramaxillary technique because it's an easier modality and there's less complications and less morbidity. Now, if you see here on the left, just the intramaxillary technique, there's a bigger cantilever there. There's a bigger AP cantilever there. And there's more complications associated with that because you're going through the sinus. And that itself is the biggest complications, maxillary sinusitis with these implants. So keep in mind, as I mentioned, the zygomatic implants present unique treatment options for patients with severe resorption, but with the intramaxillary technique, the implants come out very palatable. So oftentimes these patients complain that they feel like they have a denture screwed into their mouth and it doesn't feel much different than a denture. So it makes oral hygiene more difficult for them. So we have to be very restoratively driven. That's why we came out with the extramaxillary technique. The extramaxillary technique is more restoratively driven. And even so, sometimes we have to keep in mind these patients don't want a denture. That's the whole goal of the extramaxillary technique. So the extra sinus or extramaxillary technique helps reduce the incidence of sinusitis and other complications associated with zygomatic implants. And it's better post-op care, and it's also helps with better oral hygiene, prosthesis design, speech, and biomechanics for these patients. Obviously, with the technique, it's easier and it's easier to teach. And in my hands, I think it's a better outcome for these patients with far less complications. And I'll show you some cases where I've done such. Now, Dr. Carlos Aparicio, who's an expert on this technique, he talks about the anatomy guided approach. In my opinion, the Zygo approach is more of a classification that you look at afterwards after you place the implant. And it's great to look at a patient's CT scan ahead of time, saying this is a Zygo 0, Zygo 1, or 2, or 3, or 4. But it's hard to say I'm going to place the implant in such a fashion because it's Zygo 1 or 4. But his classification obviously is very important to know. But he basically takes the anatomy of the patient and keeps that and uses that as a guide for placement of of zygomatic implants. But for me, it's more important post-operative. Now, intramaxillary versus extramaxillary, as I mentioned. If you look at a CT scan of patients that had implants placed, intramaxillary versus extramaxillary. So here we take 3 implants that are placed using the various approaches. Here you can see, looking at the prosthetic platform, which is what's important, because that's what determines the patient's speech, the aesthetic outcomes, and their hygiene, and of course comfort. So you look at the first slide here. This is the intrasinus, the conventional technique. You see a palatal emergence of this implant, which is also got a significant buccal palatal cantilever, which obviously cannot be good. Not very different from wearing a denture. It's not ideal. Now, if you look at the extramaxillary technique, here we've used a Zygomatic guided approach, Dr. Aparicio's technique. Basically, this is a Zygomatic 3 approach. So basically, you still have a significant buccal cantilever, buccal palatal cantilever remaining for this patient. So with the Zygo 3, there you go. The Zygo 3, you have an anterior maxillary wall, which is quite concave, and the drillings before the following trajectory, which goes from palatal to the upper buccal alveolar wall, and the implant body leaves the concave part of the anterior sinus wall to penetrate into the zygomatic bone. So most of that implant follows an anterior extrasinus path. And that's really what's happened here. But you still have a good bit of buccal palatal cantilever. Now, what if you take that extramaxillary and extrasinus and go for a more restorative guided approach? So basically, you try to give the patient an ideal restorative outcome. So basically, every time I do a zygomatic implant case, we make a surgical guide ahead of time. And I try to make sure my multi-unit abutments end up in the where the occlusal portion of the molars, canines are, where the central groove of those teeth are. So therefore, my access, the screw access holes will not be on the palate too far. Therefore, you won't have a big flange. The patient can almost have a bridge. So you're basically creating a restoratively aimed zygomatic approach. So the implant platform is, like I said, mentioned over the central fossa of the teeth. And if you look here, there's not a whole lot of buccal palatal cantilever, and the cantilever is significantly reduced for these patients. So it's more of a, instead of zygoma anatomy, it's restoratively guided approach. And that's how I think people should be thinking when they're doing these surgical procedures. Because if you look at these 3 slides, the tip of the implant is always in the zygoma. Zygoma is big enough where you can place the implants with enough bone around it, but you're putting the implant restorative platform such that the patient has a better outcome. So keep that in mind when you're doing this. But in general, there are 3 main surgical procedures: the randomized, the sinus slot, which I showed earlier, and the extrasinus technique. I modified the extrasinus to a restoratively driven procedure to get a better outcome. So just keep that in mind when you're doing this. Let me just show you some cases now. So a lot of my patients, like as I mentioned, have failed all on 4s. This is a patient that came to me that had 2 failed all on 4s and a failed mini implant case. And he had a case of lower overdenture that was going to be failing soon. You can look at a CT scan and see his nasal floor is almost there. Unfortunately for him, there was no other option. Young man who's only 40, so we did an implant case and immediate load. He decided to go to Europe for his lowers because of cost, and he did all on 4, and unfortunately, it didn't work out too well for him. As you can see, the bones came out on his hand, so that had to be redone. But they did a pretty good job on his restoration. He did his restoration, but nonetheless, that's one of those things that we can offer for patients. But he had a great outcome. Let me show you a case where I did a combination of pterygoid and zygomatic implants. So this gentleman had combination syndrome, gentleman in his 50s, wearing a denture for a long time. And I did hear the conventional intramaxillary technique. I always measure the preoperative distance between nasion to pogonion to make sure I don't change the vertical inadvertently. So on this gentleman, we measured it, and I always do a incision where I spare all the keratinized gingiva. You don't want to lose any keratinized gingiva. You cannot get it back, especially in these patients that have been wearing a denture for a long time. So it's a Lefort, hemi-Lefort type sparing incision, and I spare the incisive papilla, as you can see here. The goal is because sometimes if I'm doing the extramaxillary technique, we want to bring the buccal fat pad over to cover any exposed cylinders. So this is the outline of my incision. So as you can see here, it's a modified standard Lefort type incision, and I expose the entire maxillary crest, ensures future coverage of the implant and good exposure. You need a big incision to see everything before you place that implant. Here you can see I'm dissecting along the inferior and frontal lateral surfaces of the zygoma, and I do obviously we're not avoiding seeing the orbit. It's okay to see the infraorbital nerve, but you stay lateral to it. And you also want to avoid sectioning the insertion of the masseter muscles inferiorly, because you don't want to get into the inferior fossa, because the pterygoid plexus of veins is there, and you don't want to hit the masseter muscles, because you can get into bleeding there. And I go over all that when we do our lecture in detail and our skull session. But and this is a case where I did the conventional intramaxillary technique, where we placed the intramaxillary implants using a big sinus window, but as I mentioned, I moved away from that technique. This is my retractor that I developed years ago. It's a modification of Dr. Vanderlopp's version of the retractor. As you can see, it's got a long tip, it's curved up. I just modified it just recently, and there's a second generation of the retractor now that's come out. H&H sells it. It's got some serrations at the tip and a longer tip on there, but basically it grabs the zygomatic notch and doesn't slip out, and you can aim towards the zygomatic notch, so you avoid hitting any vital structures. But anyhow, soft tissue dissection is extended, and this is, you can see here, you're making a window aiming towards the zygomatic notch. This is actually an older case where I'm placing Nobel implants, but I'll show you some Norris cases as well. Here you can see we're dissecting away the sinus membrane, and we make a big window. I mean, you might as well do a sinus lift here, but I don't do a lot of sinus lifts anymore because I found that they're very unpredictable here. Splenic membrane's intact. This is a huge window. This is the old Nobel kits here. The key is that you've got to drill always at 90-degree angles to zygoma. But the problem with this technique is that you are coming in from the palate, going through the sinus, going into the underside of the zygoma, and you have to basically determine your osteotomy ahead of time. You can't change things once you start and commit to it. We got a great outcome here nonetheless. Placed zygomatic implants. Here we started out, placed one of the second premolar, first molar area to reach the zygomatic bone, traversing the maxillary sinus. In this case, I did a zygomatic implant here, and I placed a pterygoid implant. So obviously, to avoid penetration of the orbit, you place a zygomatic notch tissue retractor, as I showed you, in the zygomatic notch. And this indicates a direction and serves as a stop during drilling and then measuring the final depth. Here you can see the implant being placed. Unfortunately, this implant has threads going all the way to the top. This is when I was using the Nobel implants. They changed it right before I stopped using it. In this case, we had enough bone where I was able to place zygomatic and pterygoid implants. But in some cases, you have to do quadruple implants, quadruple zygomatic implants. So you can see here, after we place the implant, we take off the carrier. This was a case where we're doing a conventional conversion. I do all of my zygomatic implants under general anesthesia. I don't like doing sedation myself anymore. When I was younger, I did the sedation myself, but I stopped. I don't do that myself. I want to just concentrate on the surgery. I try to always do a standard implant anteriorly if I can. In this case, I did. We placed a conventional implant, two conventional implants anteriorly as well. So here, what we did is we put on these white caps. We did a chairside conversion, and following placement of the hybrid temporary prosthesis, we evaluated the occlusion intra-op, post-op, and weekly for 1 month. Patient wakes up. They're very happy. We had a great aesthetic outcome. Obviously, we did I think at 6 months, they did a final impression. The patient had a very flat palate, so they did a Lumos verification. They did a verification jig here. Made a final restoration. And this is the final restoration with pterygoids and with a beautiful restoration with a titanium framework and zirconia restoration. If you can give me 1 second, I apologize. I'm going to get my charger here to plug it in here. I absolutely apologize. 10 seconds.
Amazing lecture, Dr. Broumand. Very interesting. Actually, there's a lot of doctors who would love to get more information on how they can attend your courses and the mentorship and start implementing this procedures in their daily dental practices as they're already doing.
All right. So I am back. I apologize. I had to get my charger here. So I apologize. I'm sorry. Did you ask a question, Doc?
Oh no, I was just saying how fantastic this is and how nice it is to incorporate this to the daily practice of the doctor who are doing already implantology on a daily basis in their practices.
Thank you. Yeah, so I mean, this gentleman went from wearing a denture to this beautiful restoration, and obviously it took a while, but remember, it takes a lot of skill, and so I advocate doing a lot of courses if you're going to do this. So remember, with these kind of implants, because of the dangers of lateral load on zygomatic implants, what you want to do is make sure you have very good cross arch stabilizations. As you can see here with the restoration, we have a titanium framework. What some people do is, even with the temporary, they do a load. They load it the next day. So basically, they take a chairside, they take a impression, they make a titanium framework, and then what they do is they make the titanium framework, use it for the temp and for the final. So that's something to keep in mind. But this gentleman he has a beautiful smile. You can see here 2 zygomatic implants, 2 anterior implants, and 2 pterygoids for him. Great result. Now let me show you a case where, remember I showed you early on where I started out my career by doing onlay bone grafts, right? So this is a case where we did an onlay bone graft with Lefort. osteotomy for a patient. Well, that didn't work. So then when he came back and we did 2 zygomatic implants for him and a conventional implant up front. And the reason we try to do a conventional implant up front is because with the old intramaxillary implants, sometimes we got rocking of the restoration. You can see here, it almost looks like he got a cheek implants, but really he didn't. Because what happens is with patients that are wearing a denture for a long time, their mid-face looks so deficient. Look how great he looks. And he didn't have a facelift. He didn't have cheek implants done. All I did for him was 2 zygomatic implants and a new restoration. It just looks fabulous. Here's a case where we did quadruple zygomatic implants and a single anterior implant for a patient wearing another long-term, denture wear for a long time. And same thing, I did 1 anterior implant. And like I said, the reason we do the anterior implant is because these patients get some rocking of that restoration up front. This is a patient that had zygomatic implants done elsewhere. Unfortunately, she was in a car accident. The restoration broke. The anterior implants got pushed into her nose. So she came to me and I did quadruple. I added 2 more zygomatic implants to her and fixed the situation. So I think that, as you can see here, zygomatic implants are a huge addition to dental implant arsenals. And if you learn how to do it, it'll grow your implant dentistry practice tremendously. Like I said, if there's any questions, I'm happy to answer them. I know there's a lot of people that want to do these, and this is a great way to add to your implant practice. So now to go over the extramaxillary technique of zygomatic implants. Norris Medical is what I use. And the reason I use it is because it's so much easier and less invasive. And it's a very predictable technique. So what we do is basically the implant is smooth and polished all the way to the top. It's got the threaded portion that goes into the body of the zygoma. And you can see here that same thing. It's indicated for restoration of a atrophic maxilla, graftless, immediate load, just like all the other zygomatic implants. Follows the same protocol as the Brandmark technique, but the difference is you bypass the maxilla. So the goal is to prevent damage to the sinus membrane, and what happens is you shift the prosthetic platform slightly buccally by avoiding the sinus membrane. And it reduces that buccal palatal cantilever, which is what I was talking about earlier. And you have a multitude of restorative multi-unit abutments that you can use, anywhere from 17, 30, 45, 52, and 60. The most common one that I use for zygomatic implants is 45-degree abutment. It's got a 2.4 millimeter internal hex, and what happens is that's going to be your go-to implant is going to be, your go-to abutment is going to be 45 degrees. Now this implant has deep aggressive threads. As you can see, the previous ones that I was using had more compressive threads that required bicortical stability. The good thing about this implant is you don't necessarily need that bicortical stability and have the tip come out through the other side of the zygoma. So that also prevents complications that arise from that. And I'll show you what I mean by that. But let me show you some cases in a second. As I mentioned, the 45-degree multi-unit abutment provides the angle correction that you need oftentimes for a lot of your cases. But the resulting torque is very high for these implants because of the aggressive thread pitch that you have with these implants. This is your typical kit. You have these diamond burrs that are these 3 barrels that are used to create a slot in your alveolar crest to lay the implant flat against the antral wall or alveolar crest, and the tip of the implant enters the zygoma above the zygomatic frontal suture into the zygoma above the level above where the zygomatic kit, above where I'm sorry, the maxillary sinus ends. So you never enter the maxillary sinus. You're basically avoiding the maxillary sinus and going directly into the zygomatic bone. And the good thing about the burrs have markings on them. So that way, when you're done with your osteotomy, you finish drilling, you have a good idea of how long your implant's going to be. So, and then you have different size burrs. You have 1, 2, 3. Each one has different diameters at the tip. And what it does is when you're done drilling, and I'll show you in a second, and this is just more description on the actual implant here. This is the different lengths on it. It goes all the way from 30 to 57.5 in the US. The 60 is not FDA approved in the US yet. You really should hardly ever need it, a 60. But if you need a 60, you can basically use a 57.5 with a longer multi-unit abutment to overcome that need. But basically what I was saying is the diameters of the burrs at the tip are different. So obviously the number 1 has a thinner diameter at the first 8 millimeters. As you can see, the number 2 is a little bit wider. Number 3 is widest. I rarely use my widest burrs to avoid getting a spinner. I think I've only had to use the number 3 burr a few times on very, very dense bone on 1 or 2 patients. But I always attempt to place my implant after my first burr. So if you look here, that number 1 burr is 2 millimeters at the first 4 millimeters. It goes up to 2.5 at the second 4 millimeters, and it's 3 millimeters from 8 to 16. And the second burr is 2.8 millimeters for your first 8 millimeters. And then number 3 burr is 2.8 for the first 3, and goes up to 3.2. So remember, the implant is 4.2 millimeters at the diameter that is engaging sling in the slot. So it's 3.2 at the tip. So I try to avoid getting a spinner when I'm placing these implants. As you can see here, the implant itself, this is a newer kit that came about. It's got medium, long, and longer burrs. And the burrs are 40, 60, and 80. There's actually even a newer kit that's out now, which has got very short, medium, long, and longer burr on there. But it's very user-friendly, and some of the surgical kits for zygomatic implants that are out there just have a bunch of loose burrs. Norris has a very nice kit that's easy to manage, and I really like that about this system. Like I said, the zygomatic burrs for groove preparation can be very handy, and this is your depth probe that comes in nicely as well. The good thing about having a bunch of multi-unit abutments that fit your straight implants or conventional implants and pterygoid and zygomatic implants is that if you're doing an upper and lower arch, you don't need a bunch of separate implants and abutments. You can use the same set for everything. But this is the 45 and degree abutments that I was talking about. They have 2 different heights. In their old system, I think now they only have 1 height. But this is the most common height that I use for my zygomatic implants. This is the whole line that I was talking about. 45 is the most common that I use for my zygomatic implants, and I use more of the 30s, sometimes 40s for my pterygoids. And also you have guide pins for measuring the degrees on your implants before opening up the multi-unit abutments. So that way you have a good idea of what angle you're going to use. This is the prosthetic phase. I'm not going to go over that. You can follow this on the Norris Medical website. It goes over the prosthetic conversion for hybrid conversion. I don't do a conventional conversion anymore. Everything we do is 3D digital conversion. But this is, I'm going to show this now. This is how the diamond burr is used to create a slot in the antral wall. And they promote, some people in Europe use a bone paste to cover the exposed cylinders. I don't really advocate that because HA can fragment and break. I like using the buccal fat pad. Like I said, if you have any questions, I'm happy to answer them. These are some of the courses that I've done, and like I said, I advocate doing a lot of live surgery courses before you actually start doing this on patients. I've done a lot of cadaver courses, and I think I have some more coming up here in Arizona. I think I'm doing one in November, and I'm doing some more live surgery courses here. But let me show you a Norris case that I did here. This is a young lady that had multiple attempts that failed all on fours. Again, we did a Norris on her. You can see here, did two separate Lefort type incisions on her to do two sides separately. Very tough, tenacious tissue, moved everything out of the way. And here you can see a small incision, a small entry point from the outside extramaxillary, not coming from the palate as opposed to the previous technique, to enter the zygomatic bone from the underside. Use the diamond burr to make a slot, and the groove is completed using the diamond burr. You use a fine diamond burr. We move the sinus membrane slightly out of the way here. Sometimes I use curettes. Here we use these cottonoids to move the sinus out of the way. You don't always have to do that. Kind of stop doing that. This is an older Norris kit that I've used. Now we have the new ones. This is a double zygoma case. So where you can see here, I'm sequentially going up into burrs. And when you're done drilling here, you're basically, I go from a 2.8 twist drill to a 3.5. With my second burr, I go 5 millimeters shy of my final depth. Here you can see the implants being placed by hand, and the implants going in, and then you put a second one anterior to it. In this case, I think my implant was too far lateral, so I did a second implant, crisscrossed it, and went underside it. So, one of the things to keep in mind is you learn from your complications. And I think that's what I teach in my courses as well, as I show complications as well during the courses. So this is my clear surgical guide that I use for all patients. You can see you want to make sure that you're clearly within that surgical guide when you're placing these implants. So here you have 2 implants on either side. So you have 4 zygomatic implants for great cross arch stabilization, great AP spread, as opposed to when you had this with your the old intramaxillary technique. So you have multi-unit abutments, 45 degrees on either side. This is a great outcome, and look how nice that looks. Obviously, this is traditional conversion that I did. This is an older conversion case. We do, I grafted the left side where I had a little bit of crack on the zygoma, but you don't necessarily have to do that ever. We did a conventional pickup, did a denture conversion. Now I don't use a denture anymore. I use the buccal fat pad to come over to reduce the risk of dehiscence over these exposed cylinders, and nice primary closure, and patient has a very nice prosthetic outcome. Obviously, the finals look a lot nicer than this, and this is one of the courses we did with Norris. I did a cadaver course, and after the cadaver course, this is a live surgery course I did with Brazil. Like I said, and I had a great time in Brazil, but I'm not sure if I want to go all the way out there for a week when I can do it here in Arizona. It's a lot easier to do these courses here in Arizona as opposed to going out there. But we had a great outcome. This is one of the courses I did with my good friend Ryan Dunlop here in Arizona, where people are a bunch of his doctors, full arch masters, and we did a 3-day course where I trained the doctors on zygomatic and full arch pterygoid implants. And this is a patient who woke up with a beautiful smile. This is my friend Dan Holtzclaw and Mike Pham, where we did I think 8 surgeries in February of last year. This is one of the patients. You see a beautiful outcome. We did pterygoid and zygomatic implants for this patient. Beautiful smile. So Dan's a periodontist and Mike is a restorative dentist, also a full arch master. And we did some great surgeries during that course as well. And this is another course we did here in April of last year. Lots of live surgery courses. This is the hands-on portion we did with skulls. I don't know why this turned sideways, but this is in Orlando. I did a course. Nonetheless, this is how it should be done, where you do skulls, lectures, hands-on to learn this. This was done here in my office. Obviously, we had lots of people there, but we did preoperative planning. We went over a lot of cases together. Then we did, everything is done digitally, PIC photogrammetry. We did exocad design, 3D printing of temporary, before and after, and this is the one-on-one mentorship. So I've moved away from doing big classes and doing more one-on-one mentorship. This is me and one of the doctors doing the surgery together with one of my assistants and one of his assistants. And this is how we do the cases now. This is a typical case that I did with one of the mentors, where we extracted all the teeth, did quad zygo. Here we did he brought his patient a conventional conversion for a case like this. This is another one. That patient came from Florida. Conventional conversion. Now, what about complications of these implants? There are complications. Remember, the most common complication is going to be your maxillary sinusitis. So intraoral complications are about 1.2%. But this is one of the complications. Less than 1% of patients with old implants can get a cutaneous fistula. This happened 8 or 9 years later. This is an old Nobel implant. Bicortical stability. Patient gets this. You have to go back and do an apicoectomy on these implants, unfortunately, and cut out the fistula. This patient had an implant done somewhere else, and he developed oral enteral fistula, but he doesn't want to have the implants removed. But these implants need to be removed. This is a patient that had an oral enteral fistula done somewhere else, and I advised her to do a buccal fat pad repairing. We did it, and it was repaired properly. I was able to repair it. This patient had an implant placed in the orbit somewhere else, and I was able to remove those implants. This implant was done elsewhere and placed in the infratemporal fossa and had to be removed. So you have to keep in mind that adequate training is needed to do these, and that's why I recommend one-on-one mentorships and or live surgery courses before you do these. But what I do now that's different also is we don't do these implants chairside conversion anymore. Everything I do is precise. We do a precise implant capture. Everything is digital. So what I do is when we place the implants and the multi-unit abutments on, we take a camera, screw on these multi-unit abutments, take a picture, and it creates a file, an STL file. I send that to my lab, and they create a design for us, and we print that. We already have a soft tissue registration, and we create a digital model of the teeth, and these are our transfer flags. So these are the flags that go onto the teeth. This is my partner versus my fam. This is my 3D printers that we use to print the teeth in the class. This is a 3D set of teeth that are 3D printed. Here we're painting them with GC America resin. This is a beautiful temporary. It looks gorgeous. This is the Norris team at one of my courses. This is a couple of our lectures that we did. And for those of people that do these and they're not comfortable doing them early on, they can do zygomatic implants guided. Norris makes it easy Zygoma. So that way you can do these safely. Or, what I do is I tell doctors that come to my mentorship, they can continue bringing their patients back and do these mentorships over and over until they're comfortable doing this on their own. And that way they don't jump into this until they're comfortable with it. I've had doctors that brought back patients 3 or 4 times, and we can talk about the details about that later. But that's what I would do, is I would recommend having doctors come back and do this at a pace where they're comfortable. But nonetheless, I know there's a lot of doctors in Global Summit and the Academy of Oral Surgery that want to move on to full arch or zygomatic or pterygoid implants. And I think knowledge is everything. So you have to learn more about it, and if you're interested in doing this, you have to read more about it, educate yourself, and obviously, implant dentistry is growing, and this is something that's been around for a while. And just zygomatic and pterygoid implants are getting more attention now at the forefront because more people are posting cases. But I've been doing these since 2003, and I did these back in 2003 because a couple of my own all-on-4 cases failed, and so now it's almost 18 years later, and I'm happy that I'm able to share my experiences from my own failures and successes. But I think that was my last slide, and thank you. Like I said, this is my email and that's my Instagram. So please, if you have any questions, contact me. Thank you, Dr. Javid.
Thank you. Thank you, Dr. Broumand. Beautiful surgeries. Amazing. You showed us all the different ways this has been done out there, and then you showed us the best way, as well as beautiful restorations you did. I mean, that's amazing. That the fact that I think half of the battle is the restoration. I mean, you can place these implants, but if you don't know how to restore them and you don't train them how to restore them, then it's kind of useless, right? In their hand, patients want to go home with the immediate restorations right after the surgery. That's what they're paying the money for, or whatever it is, and doctors should be trained how to restore those cases, and you showing them obviously the best way to do it digitally. You're doing digital printing, and that's basically the latest technology, and yeah, so exciting.
Yes, absolutely. Yeah, the digital dentistry is the way to do it.
Right, that's amazing. And then you hold this, so people would contact you to schedule this, and then just a little bit more information on how the patients, they bring their own patients to you, or you?
Well, they can bring their own patients, or I have lots of patients that contact me. There are lots of patients that contact me that want to be a patient, and they can't afford the treatment. So then what happens is I have patients on a waiting list that want to be treated, and then they become patients in my courses or patients during the one-on-one mentorships.
So that's not a hurdle. That if you don't have a patient, it's not a hurdle. Like you have the patients for them ready to do this. So they don't have to worry about that. Yeah, no, that's great. That's great. That's great. And then you also train them on guided. You'll train them on how they could do it guided. Yeah,
we can do that. Yeah, absolutely, we can. And obviously, I recommend learning how to do it freehand and guided, obviously, because you need to know how to do it, because sometimes guides will malfunction, as you know.
I agree.
And that's why I think it's important to know how to do this.
Absolutely. Absolutely. And of course the complications, right? I mean, that's the most important thing. Whatever we do, whether it's just an extraction or whether it's simple implant placement, we should know the complication of what to do, what not to do, and
absolutely.
Yeah. So that amazing. Yeah, I would love to learn more about it myself, and and it's amazing. This your mentorship is really a fantastic way of doctors actually getting their hands on it immediately. So because a lot of people take courses, but they don't get to do it, and then they just never do it. So this is
No, they,
actually
yeah, the doctors that come here, it's 2 days. They get to do it all, and the first day is lecture and practice on skulls and scullies, and actually in November I'm doing a cadaver course as well. But
great.
the one-on-one mentorship is every month. It's all the time, and but that way, they can come anytime. We schedule it 2 days, and they get to do the surgery. So they come, they do it, and they go home, and then they get to do it again.
That's amazing. That's right.
Yeah.
Well, thank you so much, Dr. Broumand. We really
Thank you.
appreciate you taking time on your Sunday and sharing it with us.
Yeah.
And,
Thank you for having me.
and we really appreciate you, sir.
Thank you. Thank you. Have a wonderful day.
You
And
the
I
same.
look forward to seeing you soon.
Thank you. Thank you.
Bye-bye.
Bye bye.